you're looking at your red boxes, that is so that you can distinguish your mechanisms of action. If I were studying for this, I'd probably try to take this picture so that you can kind of remember where everything goes. This top one and the bottom. And then kind of look at that and say, okay, what are some of the different weird adverse effects? What are some of those different clinical uses? So I told you guys that I would talk to you about the clinical uses for some of these. So when you're looking at the table at the very beginning, just pay attention to the bold medications that are there and kind of associating them with which type of seizure, okay? For the one that is your absence seizure, remember both of those options that we have available to treat our absence, but just the ones that are in bold. When you're looking at the slides, I know it tells you and further stratifies the type of seizures that the patient is having. What I want you to pay attention to on that part of the slide are like, yes, we're using these for seizures. That's all I want you to, yes, it's for a seizure. When you get to the slide where it talks about like several different breakout ones. Let me show you an example. So like these off-label uses of this, if I were asking you something on this, I would be like, oh, they can use it for neuropathy. You can use it for epilepsy, which is not the same exact thing as like a base, like all of the different types of seizures that we're looking at, right? But if you saw like generalized tonic-clonic, I'm not going to be that specific in asking you which one. You could see it in the vignette, but I'm not expecting for you to like remember all of these. This is like our antibiotics all over again with like all these clinical uses, right? So trying to pay attention to that versus, and then you'll see some of these where it's like our pregabalin, our gabapentin, okay? Oh, I use this a lot for neuropathy as well. You see that it's overwhelmingly used, and typically when we're using it for some type of neuropathy, nerve kind of damage. But I also do use this in seizures, just blanket it as seizures, okay? So that's all I want you to know when you're looking at these. You're trying to go through and say, all right, what are those really weird ones like restless leg syndrome? You're going to see some of the drugs that we look at where those are dealing with restless leg syndrome. So make sure that you're looking at this. Overall, they deal with seizures. There are some of those very popular off-label things, and whenever you hear me talking about them, those are the ones that I want you to pay attention to, okay? Okay, so your topiramate or Topamax, very popular medication that's used. You see here, again, we're back in our sodium channel blocker. What's different about this one in our GABA activity being enhanced, but what's different about this one is you have that AMPA kainate activity. And essentially what that's doing is it's like increasing the glutamate activity, right? And we said that we're trying to say, not enhancing our glutamate, it's antagonizing our glutamate activity. Normally what AMPA does is it enhances the glutamate activity. So that's why we are antagonizing it, because we want to slow everything down, okay? So that is your AMPA kainate activity, which we haven't seen in a lot of places, okay? So that's a really awesome one. Looking at my clinical uses, again, several seizures. I do want you to pay attention to LGS when you see LGS options that we have available, okay? Migraine prevention, we're going to talk about this a lot next semester, but this is one of those medications that's very versatile for us to use for that, and you will see this used a lot for that. Looking at your other off-label things, this is kind of something where we're using them several times in like adjunct type of situations, but you see that we can use these for a lot of people who have eating disorders or something where they're gaining a lot of weight from their antipsychotic medication. We use this to kind of combat that due to that weight loss adverse effect. So when you're seeing this binge eating disorder, a lot of those patients, depending on if they're trying to vomit after, this could be a good thing for them, but you have to watch people who have conditions like that, because whenever you do put them on something that causes weight loss, even stimulants, they can become addicted to them because they are losing the weight. They're gaining their end goal, and so they will utilize their medication to try to get skinnier. Okay, so just watch out if you do have somebody with those types of disorders, but we use them for that as well. Clearly it's well absorbed because we have oral formulations of it, and then our interactions, just making sure that you're looking at several interactions with our SIPs. We have still our contraceptive interaction where it is decreasing the effectiveness of my contraceptive, but my contraceptive is also acting now on my medication and decreasing the effectiveness of my medication. Okay, so if that happens, then I can have where I'm having to use higher doses, which means more side effects. I'm also potentially having more seizures if I get put on that contraceptive after I've been managed well with my Topaz. You put me on a contraceptive and now I started to have seizures. That's because my contraceptive is decreasing my effectiveness of my Topamax or my topiramate. Okay. And then you're seeing here with your phenytoin and your carbamazepine, which are other options that we could be using in these patients, that I can again have my Topamax or my topiramate levels being decreased. Okay, so just watching out for these seizures or these interactions are a big deal because we can have seizures. Also understanding that with this medication and some of the other medications, you'll see that it takes a couple of weeks for them to work. Unless we're using like our rescue seizure meds that we're going to talk about in a minute, it takes a while for these to kind of build up in the system and actually start to work. So kind of how when we talk about antidepressants, you'll see where some people will start to see effects from them, but to get the full effect, it may take up to 6 months, 4 to 6 months, sometimes it'll vary, okay? So these are the same things when we're talking about some of these meds, is that it takes a while for it to actually build up in our system and work. Adverse effects, these look kind of similar to what we've seen before, okay? So again, just think about it as it's slowing a lot of stuff down, right? So drowsiness, sexual dysfunction, my loss of appetite, which is why we see that weight loss, okay? So it's slowing down everything. Memory impairment, I'm just not firing how I used to. When we're looking at our more serious things, please be very cautious in your patients who have chronic issues with kidney stones, because this can cause kidney stones, and then if I had an underlying history of that, it is definitely likely that it could be aggravated and those stones could be big enough to where I can't pass them on my own. Your metabolic acidosis, all of this stuff now, when you're looking at it, just think of it as you're increasing or elevating things. You're elevating their pressure in their eyes. You're elevating them making kidney stones, metabolic acidosis. So that's kind of how I say these two things are contrasting, the common ones versus the serious ones. And then your pregnancy, don't use it. In pregnancy, for the most part, is what we will do. So if I am asking you about this, I would tell you that you're not using it. You will see pregnant women on it, okay? But it'll be beyond your scope. So for your scope, what you will be thinking about is, oh, they're pregnant, don't use topiramate. Is it a category X? No, but it's not an A or a B, okay? So I asked you that, it is a no. Keppra. So your levetiracetam is a very popular medication. You probably all have heard Keppra being spoken before. People usually say Keppra. But looking at this, your mechanism of action, just making sure that you're understanding that it is, again, trying to do what everything else was doing, right? Decreasing the firing that's happening and trying to say, all right, let me stop this activity that my patient is having with a seizure. You see that I have an IV formulation, so that tells us a lot, right? It's going to hit that bloodstream. It's going to be immediately available for my patient versus whenever I'm looking at my oral options that I have. You see that we have it as an adjunct for several different types of seizures. We are safely using this in our children who are at least 6 years old. When you're looking more in depth at this, I just want you to remember the age of 6 as the lowest. I'm not going to say, oh, is it a generalized tonic-clonic versus a myoclonic, okay? So just 6 and up, we're good with this medication for a seizure, okay? You see our LGS again, so remember to, like, when you're studying, make you a little column for your LGS medications that we have that are approved. And then when you're looking at our IV formulation, we don't typically rush to this if somebody is in the hospital. This is if they're saying like, hey, I can't take my medication for some reason, and you know that somebody is on Keppra, that is why you're using it. We're going to talk about status epilepticus, and when we talk about that, again, that is like it's an emergent situation. We're really trying to hurry and stop that person from seizing. So that is when you can sometimes also see us using the Keppra. Okay. Good PK parameters. This is, I think, the first time with any of our drugs that we've seen that O1 or 3 substrate. So that's an organic anion transporter. So just that's something that's weird for our PK parameters. So just kind of look at that. Adverse effects, pretty well tolerated, right? Most of these are going to make them drowsy and weak. So just these are basic side effects. And then I have something that's also preferred in pregnancy, right? So we were talking about most of these we're not really using. Now I have some meds that are popping up, right? We had one yesterday, now we have this one that I can use. So looking at this is giving you all of the other agents that we have available, some of which are used now more. Some of these are more often that we do use them. So it's summarized instead of them having an entire slide on a little table for us. So when you're looking here, make sure you're looking at the medication. You see that your lacosamide is also a controlled medication, okay? So make sure that you're paying attention to those. Your mechanism of action, again, just making sure that you're glancing over them. All of them are trying to say, hey, let me enhance my GABA activity and stop all of the firing that is occurring. And that's summarizing it. Make sure that you're looking at the big things that these are doing, because they are all a little bit different. Our indications, there's nothing special here that I want you to look at when we're looking at indications, except for you see that you can use your donacetamide with your bipolar disorder patients, and that you have your felbamate for your LGS again. Okay. Now, looking at my adverse effects, make sure that you're paying attention to the adverse effects, and then looking at your vigabatrin, understanding with this because of the vision loss that people were saying, and this turned white because I changed the color. Make sure that you see there that it has one of those restricted distribution programs, because they can potentially lose their vision. So they have to register, we have to register, the provider has to register so that we can dispense the medication, making sure that we're telling them, hey, because you can lose your vision, we are wanting you to know that before you use your vigabatrin. Okay? So another V with a V. You see if there's any other. Oh, when you're looking at your zonisamide, remember I said this has bipolar. You're also going to watch out for your SJS. And then also this has sulfa in it. So for anybody who is allergic to sulfa, that is a big thing with your zonisamide. And then the way that I try to remember about my my felbamate is that I can have anemia or my liver can fail. And then if all else fails, I can use this medication when I'm talking about a seizure, when I'm talking about my LGS. It's like one of our ones that's down the line. So your felbamate is like your down the line medication, anemia, as well as that liver failure. And then your tiagabine is another one. Again, we can use this with several different types of seizures that patients can have, and it's just abbreviated here as partial. But we're watching out again because we see that SJS and that TINS. So first sign of you seeing any SJS or TINS, you're telling your patient to discontinue the medication. Those are the big things. Just make sure that this white is, you change it back. I didn't realize that we changed colors. Yes.
With use of lacosamide control, then how are we?
How are you what?
You said lacosamide is a controlled substance.
So where it says C5 under VIMPAT, under the name? Yes. When you see that, that's typically how we abbreviate them. It'll say C5, C2, whatever it is under. And you can also see it as scheduled. But most of the time when we're writing on our drug bottles, it'll say a C and it'll tell you the number on the bottle.
Some of these say drug notes. Is that what we're remembering about them, or remembering what we think happens?
So we remember what we are thinking that happens. So when it says unknown, If you see an unknown and it has nothing after it, then that really means like we don't know. Just like when we talk about Tylenol and stuff, we'll say mechanism is unknown, but this is how we believe that it happens. We remember the but how we believe that it happens. Yes. So let me I'll go back to that once we finish through this slide so that you can see the chart that's at the very beginning, and then I'll review it with us actually looking at it. Okay, our check on learning. 37-year-old patient reports developing a rash 3 weeks ago and asks if it's due to their carbamazepine. Which of the following is the best response for this patient? I heard one person over here. Anybody else? Right? So just make sure, again, adverse effects are the big things that we're looking at when we're going over these, and then our mechanism on how they're working. And then most of these I can't use in pregnancy, so it's easier for you to pull out what you can use in pregnancy. And also most of these I can't use with my contraceptives, but there's very few of them where my contraceptive is acting on my actual medication that I'm taking. So annotate those, right? Because we know, cool, all of these I should expect to see something happening with my contraceptive. But when am I actually seeing that my contraceptive is affecting my drug? That didn't happen a lot. Okay, so pull out the abnormal things and put them onto the side for you to remember, hey, these are what are happening in these drugs. All right, so when we're talking about our special situations, you have several different conditions that can happen that can lead a patient to seize. When you're looking at your febrile seizures, essentially what this is the patient's or the child's body is heating up quicker than the body can handle it, right? And so it can sometimes lead to a seizure. When we see this, most of the time it is not something that lasts for a very long time. And in some of the kids who do have this happen, they will have repeat issues with febrile seizures. We don't pre-treat for them usually. Because there are some times where these don't last for a very long time, but you can have where it can end up in a status epilepticus or SE type of situation. So when you look at this, just make sure that you understand that you have, you treat the fever. You treat it just the same way as you would a fever nowadays. My nephew gets seized all the time. And at first I was like, oh, he probably has like epilepsy or something. And they did all the neurological tests because that's what you have to do. If you see these, you have to work that patient up to make sure that it is just a febrile seizure and that there's not any other neurological damage that's happening. So you're just treating it with your acetaminophen to try to cool them back down. You know, all the things that we say with like their clothing and not making sure that you're not making them super hot. Just cool them down, okay? And Tylenol, sometimes we will alternate Tylenol with our ibuprofen and try to break that fever in those kids. And then you see that if they do end up having status epilepticus where it has been prolonged, then you will see where the phenobarb is put on, and you can potentially use the diazepam depending on how they are seizing. And remember, diazepam had the diastat, which was that rectal formulation, so you can quickly administer the drug to the patient. Yes.
Would you prefer to use like IV Tylenol in a situation like this?
No, most of the time they're going to be at home when it starts to happen. And you can immediately try to start giving something. So like for us with my nephew, as soon as he starts to warm up, she starts giving him Tylenol right away before he even gets to the 103, 4, because he is like up there. And sometimes you'll see where these kids, it's just a matter of, it's not so much the number, it's the matter of how quick they get there that causes the seizure. So when you have a child or you get a patient that has this, they just need to make sure that they're paying attention to how that kid presents so that they can try to get in front of it. Because we are not prescribing phenobarb anymore like prophylactically, especially in a kid because it's so much. It's like side effects, and you don't know when it's going to happen. So you just try to treat them like you would treat a regular fever. Yes.
Yeah, so that last question, the ones that have seizures, no pheno, but like drug of choice you would say is the diazepam.
So it depends on where you are, and it depends on what is available in the pharmacy. Most of your rooms in a hospital, you're gonna have your diastat. You will have the diastat or your diazepam, the rectal formulation, or it'll be like in the Pyxis, but so will your phenobarb, so it depends on what they prefer. I just like, and what I've seen in a lot of codes, especially in our seizure patients, was that we use diastat a lot, especially our pediatric patients. It was just easier. They can't swallow, depends on how bad they're convulsing. But yeah, you could push something. So if I had a line started, when somebody is seizing and you're trying to start a line, also kind of difficult because they're moving and you're trying to place a line. It's sometimes not fantastic. So I can easily stick something up your butt and I can stop you from seizing. And then we would start a line and put them on some type of maintenance. Y'all, I'm trying to up your rectum, okay? I can easily administer a medication rectally. There you go. Y'all are so. All right, our status epilepticus. This is what you continue to hear us talking about, right? So this is one of your seizures. Typically a seizure isn't lasting for a very long time. Once you hit that 5-minute mark, or they seize, and then they're like, when people come out of a seizure, sometimes they're kind of disoriented. They like don't know what's going on. They're trying to figure it out. Like, I was standing up and I was fine, and now I'm on the ground and all these people are around me freaking out. So like, if that happens and then they go back into a seizure again, that is also what we will say they're in status at that point. So your big job in these situations is to make sure that you are stabilizing your patient and supporting your patient. We were at a pool party and somebody started seizing. He hit his head on like the countertop of the bar area and then seized, and everyone just stood there because nobody knew what to do. And I was like, somebody grab his head. I could call off I was in pharmacy school and I was not ready to risk my life yet. So I was like, I know what to do, but I need somebody else to do it because it is very, very scary. So make sure that you remember all these things that we teach you in class when you actually see it in real life, okay? So our big thing that we had to do was just essentially stabilize him. When somebody is in status though, they end up getting transported to the hospital because you're not going to be able to treat them and they're not going to recover fully from that seizure that they had. The longer that I'm seizing and I'm having these convulsions, the worse that my outcome is going to be. So that's why we try to get them out of status. So you see we do all of our different labs, our tests, make sure there's not drugs. Guess what that person had been doing? They were smoking, I think is it called K2, like the fake weed or whatever, and his body can't handle it. And it happened to him several times before and he just kept doing it. And they were like, yeah, he has seizures now because he keeps smoking whatever this stuff was. And I was like, this is what happens when you go to pool parties with people you don't know. I was so upset. I was like, I'm out, okay? So remember that could always be like an underlying thing that is happening with people that sometimes will cause them to have these seizures. And the way that people make drugs now, you don't know what's in drugs, okay? So like, try to talk to people that are around, and also try to, when they come in, you're doing your tox screen also. Sometimes you'll see hypoglycemia occur. If that is the case, then you'll try to give them, we'll do fluids, we'll give them stuff to help their glucose levels go back up. And then, of course, I'm going to give them something to stop the seizure. There's going to be so many people around, like when that person comes in to the ER, that like everybody is doing something. It's kind of like when you have somebody and you're thinking that there's a stroke or something. Like everybody comes in and everybody has their hands in something. So this is kind of the same thing. When you give that emergent medication, your emergent medication is like your abortive medication. It is stopping the seizure. But after that, because they hit status, now you have to give them a maintenance drug to make sure that they don't start seizing again, okay? So we'll talk about our emergent medications, which are our abortive ones. They're stopping it. They're stopping that seizure. And then our maintenance meds are going to be put on after, which would help them not have another seizure at that point, okay? So emergent will always be followed by your maintenance, okay? When we look at these are all going to be options that we have for IV. Again, if you can't get a line, we have some where we can do We have IO options, and then with our diazepam, we had our rectal option that's available. So when you have IV or IO access, we prefer to abort a seizure with our diazepam or our lorazepam, okay? This is if you have access. If you don't have access, you'll see sometimes where we can do our midazolam, and we'll give them like an IM injection to try to hurry up and try to stop that seizure. But hopefully, we will have and be able to gain that IV-IO access. So you can be trying to get somebody to get a line, and you can have that other person pulling up the med, and then if they don't have the med, they're making sure that there's some Versed or midazolam around for you to get that patient out of status. And then your urgent medications that you have that you can kind of follow on with, we have our fosphenytoin, our phenytoin, and then you see our off-label uses with our VPA or our valproic acid, your Keppra, and then your Vimpat or your glucosamide, all of which I have seen used. So make sure, again, that you're remembering if you have midazolam and that's all that you have, it is okay for you to use it. But if you have IV or IO access, your lorazepam and your diazepam are usually where we like to go because they have a very, very quick onset. They're tolerated pretty well, and then we just get a lot of our great side effects. So you see your lorazepam less lipophilic, so therefore I'm not going to have all of that hangover kind of feeling that some people will feel whenever we give them that diazepam because I'm in the CNS. Okay, I don't have to worry about any renal dosing or any of that. We love to use our lorazepam. Your diazepam, we have more adverse effects, but we also have more CNS adverse effects, but we also have more formulations that could potentially be available if we don't have that IV-IO access. And then if somebody has hepatic impairment, we need to be cautious with that. Your midazolam, you see several different options. Again, I don't have to worry about my dosing, but I typically would go to this if I didn't have my IV-IO access, okay? Just inject them. You guys don't need to remember this, those maximum infusion rates, okay? I'm not worried about you doing that. All right, so my refractory medications that I have that are available to my patients. This one is looking at my phenobarb. IV option, in all of those, we would prefer to do the IV options of the medications that we just talked about. But my refractory medications, this is meaning that I have tried to put them on these medications and they're still not coming out of status. What else do I have that I can give to my patient? So you see you have your phenobarb, midazolam, propofol, and then your pentobarbital and ketamine. So several different options for you to get creative to try to get that patient out of status. What I do want you to pay attention to is the different types of the hemodynamic stability of your patient, right? Because some of my drugs can potentially make them worse. So if I have a patient who's already hypotensive and I give them midazolam, I can see them tank, right? Because now I have an additive effect on what's already going on with this patient. So make sure that you're looking at the vitals before you're starting any of these meds. My heart rate is probably going to be up because I'm having convulsions, okay? So this tachyphylaxis, we worry about it, but just make sure that you're, again, looking at their vitals whenever you're giving them their medications. We start with midazolam because it's easier for us. It's not, we talked about propofol a little bit and how we have some of the different side effects. We talked about how we have to monitor different things with this medication because of the lipid formulation, how it's made. So we like our midazolam because it's just a cleaner drug for us to use. But if it's not working, right, then you're looking at your propofol, your pentobarb. We talked about our the pentobarbital. We try not to use these things long term, right? But when we have somebody who's in status, we are trying to stop that seizure. That's all that we care about. So if you're not getting a response to our other medications that we just spoke about, I'm going to refer and I'm going to go to these. So these are my refractory medications. They're not responding to these. They're not responding to my emergent medications. They're not responding to my urgent medications. So now I have to go deeper into my tool bag to say, what other medications do I have to stop this from happening, okay? So again, what I want you to pay attention to is all of the different things that could potentially happen whenever you administer one. because I can give you your patient and say, all right, what is a good option in this patient who has not responded to my urgent medications and they already have a high level of, they're hypotensive already. So I'm gonna look at something and say, well, I know for sure that I don't wanna give propofol, right? Because propofol is one of my biggest ones that is probably gonna cause me to have that hypotensive response. Maybe I could use which drug on here, right? So like, think about the patient that way, approach them that way. A lot of the times when we're picking a drug from here, it's because of how they're doing hemodynamically. Like, are they stable or not? Somebody had a question? No? Yes. Well, yes, you can. So, but on the other side, most of the time when we're trying to give it, we're not using our IV formulation of it. It's the way that we're administering it, but it's the same drug. But sometimes, yes, you can. What I would do is if my person wasn't responding already to it when I tried to push it IM, I would probably go to something else because that means that I need to, but this is gonna be running. Like this is gonna be an infusion that we're giving them versus like just that one injection. So the dose is going to be larger. It is possible. Yes, it is possible that you would give more than one. But that's just because it's given two different ways. I'm not gonna do that nuance when I ask you that question. If I ask you a question about how we're administering it, it would be because they're seizing and you can't get a line. I would ask you like, okay, well now what's your drug of choice? Like what would you do? What do I do if I can't have my IV or my IO access? What was my drug of choice on here? Midazolam, right? So if I asked you something like that, I would ask you in that sense. I wouldn't give you midazolam here and try to trick you and be like, okay, is this a refractory med or not? Yes, midazolam is one of your refractory options that you have. But in all of my refractory options that I'm using, these are going to all be IV options for you. Yes.
What case would you use
Over diastat. So in these situations, I have not ever had a situation where we couldn't get the IV or IO access, so I don't know the answer to that because I have never had to personally do that. Oh my God.
Like if you're asking like.
If I ask you a question,
IO, like
if I ask you a question, you will know what you're supposed to pick and the answer choices will be there. Okay, let me not say it like that. I won't give you something, like if I asked a question like this, it would be essentially like kind of similar to what I was just telling you, right? Like it would be clear cut. Could I potentially use midazolam in an IV situation? Yes, but not when I'm initially trying to stop status. When I'm initially trying to stop status, I'm gonna give this to them likely IM. Initially. But if they are refractory, I'm going to get a bag, I'm gonna hang that bag, and I'm going to be infusing midazolam now. 2 different administrations for 2 different situations. But it's the same drug. So I don't know, like if I asked you, it would be clear. I would tell you that the person was refractory and they didn't respond to any of your immediate medications that you had. So then that would mean that they're refractory and you have to use one of these medications. That's not your question? I can't tell you what the question would be on the exam.
So you said diastat and pediatrics and midazolam both be used for if you don't have IV or IO access.
Yes, but if I ask you a question, you would know what to do. I wouldn't give you both of these things this way. When we're talking about status, I would prefer to use my lorazepam or my diazepam in an IV or IO formulation. Yes, I do have the option to use my diazepam in a rectal formulation as well, just like I have my midazolam as IM. So you're saying which one would I pick in that situation? I could pick either one of those options. So if I gave you an exam question, I would have to be clear to tell you, I said the patient didn't want to get stuck by a needle or something. who cares, they're seizing. But like, I wouldn't do that. So I'm telling you, like, if I ask you something, you would know. Just know that you have all these formulations. Don't worry about the test, worry about this information, and then the test is gonna come. I can't tell you what I'm gonna put on the test, okay? But if I ask you that, it would be a fair way to ask you that, okay? Looking at your older patients, we have a lot of older patients who can also potentially seize. Some of them will also seize because they've had some type of traumatic event. Okay, so when we're looking at this, just make sure that you are understanding that a lot of our medications, we said, had renal clearance. So if I have anything that goes through renal clearance a lot, then that means that I'm going to need to be monitoring their creatinine clearance to make sure that they're eliminating the drug. Because if they're not eliminating the drug, then I'm very, very, very worried about them having increased issues with those adverse effects that we can see. And I don't want to make my older patient more drowsy because a lot of these meds are like dealing with drowsiness. Now I've made them drowsy, grandma falls, now we have more issues because guess what she did? She broke her hip when she fell, right? So that's why we are worrying about and making sure that you're going to monitor that renal elimination that they have. So this is just looking at the several drugs that we saw that all make you look at your renal elimination, make sure that you're adjusting the dose based off of their creatinine clearance. You'll go to that package insert, right? You'll be like, where's my creatinine clearance? Then it'll tell you, all right, this is now the new dose that you're doing for this patient based off of their creatinine clearance, okay? When you're looking at your carbamazepine, you see that you can have decreased clearance in these patients because, again, that is one of those meds that is going to be based off of that renal clearance that you have. Phenytoin, as you get older, you're likely to see that you have less protein around for it to be bound, okay? So that's why you see that they have decreased protein binding. Therefore, what's going to happen to my levels of phenytoin if I don't have a lot of protein? It's free, it's going up, right? More toxic effects that I can experience in these patients. If I have renal failure, I'm not eliminating a lot of that drug. What's happening to my levels is going up. More toxic effects, okay? So just look at these and make sure that you're understanding, hey, this is what's happening in these patients with these meds. And it makes sense because their creatinine clearance is slowing down, their protein binding has decreased, okay? Preeclampsia. So you will have patients who can potentially be coming into you for their regular care and they're going to OB as well. When you're looking at preeclampsia, this is essentially like them having a normal person and then they get pregnant and after like that 20th week or so in their pregnancy, they can develop hypertension. Depending on how bad it is, you have some people where they have an organ damage. It can get very, very bad. Some patients end up hospitalized and you can have it with one pregnancy and not with another, but you are likely to see like it again if they have already had it before. So when you see your eclampsia, this is like the next step up where now they've actually started to seize from them having that hypertension, okay? So I will tell you what the condition is. You will then say, hey, what drug should I be using? So if somebody has hypertension while they're pregnant, we have several different drugs that we can use, but the ones that are approved for pregnancy you have are your methyldopa or your labetalol, okay? So remember, my issue with preeclampsia is hypertension. My two drugs that I have are my methyldopa and my labetalol. Now, I can control their blood pressure with those medications. Sometimes I will put them on those medications while they're pregnant and they're perfectly fine. They go on about their day and they're taking this medication every day, right? Let's say that you get me and now I have eclampsia. I am seizing, okay? My drug of choice that I'm using to stop that seizure is going to be my magnesium sulfate. So underline, bold, your magnesium sulfate. That is specifically for your seizures. If I just have my hypertension and I'm not seizing, we're not giving me my magnesium sulfate. You will see though, if somebody is actively like they're in the hospital, we're gonna deliver them, they're not taking their methyldopa or their labetalol at that point, we will sometimes give them that and we will also add on our mag sulfate to prevent them from having seizures in that postpartum time frame as well, okay? So we use it to help us with the seizures, but we can also try to stabilize our patient, and we'll see where sometimes they do put this on because they're like, oh, this person has had it before, we've seen them actually have eclampsia, and we're worried, so we could potentially prophylactically treat them with the magnesium sulfate. This is just telling you how it works, that it's trying to decrease the amount of edema that they could be potentially experiencing on the brain, which is a result of the hypertension that they're having, and so therefore it is going to decrease the chances of them having seizures. Adverse effects, that flushing and sweating, so it's very well tolerated, which is why you will see it. Just make sure that you're watching out for any patients who have any renal failure. This is your patients who have epilepsy and they become pregnant. So very interesting combination. We do try to use our monotherapy so that we don't have polypharmacy. They're already taking other medications, but your two very good options that you have are your lamotrigine and your levetiracetam or your cetetrim or your Keppra that you can be using for your patients. Make sure that you are not trying to, you want to keep them on the lowest dose possible because we can potentially see some malformations that occur, but it is not teratogenic in the sense that it terminates their pregnancy, okay? So we can potentially see some of these issues occur when we're looking at these. And I try to say the lowest dose possible for any of our pregnant women, but specifically when you're looking at these medications that are listed below, so your phenytoin, carbamazepam, phenobarb, BPA, topiramate, your benzos, those are the ones that are more likely to cause those malformations, okay? So always make sure that you're keeping your dose low, because if I seize and I'm pregnant, what if I fall and I fell on my belly, right? Like you have to just be very careful when it comes to this. But you don't want to drop their dose super low to where now they actually can be more prone to having a seizure, okay? So dose adjustments may have to happen here depending on what type of medication they're on. Also, protein binding changes when they're pregnant too, okay? So you're gonna have to do some dose adjustments once you figure out that that patient is pregnant. Folic acid should always be something that someone takes whenever they're pregnant, so make sure that you're having that. And then again, we still are worried about like if somebody, they shouldn't be at that time still having a contraceptive on board, so that should be off anyway. Okay. So this is a summary chart trying to tell you essentially with all of our anti-epileptics, like what do you have where it's decreasing the effectiveness, which medications do you have an option of not having your contraceptive be affected at all by your anti-epileptic that you have. So any of your contraceptives, and these are the ones that most people are on, when you talk about estrogen base, and then when you look at your progestin implant, we'll learn more about contraceptives next semester, but these are the ones where you can see the decreased effectiveness, which means that they can potentially have a baby, right? Because their contraceptive isn't working. And your estrogen component, you can increase it, but lots of side effects come along with that, so that's why we're worried about the potential of just increasing it. So you do see, hey, I can change them to my medroxyprogesterone depot injection or my levogestrel IUD that I could use on my patient, or your intrauterine system or device. So we have options. We also have the copper IUD as an option. We don't love copper IUDs anymore, but it is also an option that you can see those used. So this is just a summary chart telling you like, hey, what are my drugs that are more likely to be affected, and then what are my drugs that I'm not really worried about, okay? My contraceptives that I'm not really worried about. So when I'm looking at this, look more so on this left-hand column because these are your contraceptives that your patients are gonna take. So remember your left hand where it says decrease effectiveness. If you remember that, then everything else you're not worried about, okay? So remember your drugs that have your decreased effectiveness, and then everything else, it's like, okay, I can change the contraceptive to something else if I do see that decreased effectiveness. But if I'm on any of these bottom half drugs, I'm not worried about changing them to anything else. I can give them their anticonvulsant with their contraceptive, and I don't have to adjust anything. Sexual dysfunction, we already said this was a big deal with all of our medications, bless you. So make sure that all you need to remember from here is that you have your lamotrigine and your oxcarbazepine. There are the ones that are your least, they affect your sexual dysfunction the least, and then your highest incidence of your sexual dysfunction is above, okay? So remember that we had several of our medications. I don't care about the mechanism, I don't care about the percent. I want you to know when am I likely to see it and when am I least likely to see it. So this improved sexual function is when you're least likely to see these medications affect their sexual performance, okay? Osteoporosis. So we have a disease that could potentially cause me now to have osteoporosis. So because of my epilepsy, I can potentially be more prone to osteoporosis. So when you're looking at your prophylaxis for this, you see that all we're gonna do is give them vitamin D. We can see in some situations where we'll try to add on like a low dose of estrogen, but that's controversial because you can see where sometimes this can trigger a seizure, okay? So your big thing here is that we're just gonna tell them, hey, make sure that you're having the amount of vitamin D that you're supposed to. So for this osteoporosis slide, just know that if I have epilepsy, I'm more prone to having osteoporosis, and all we're gonna do for them is vitamin D, okay? Suicide. So with this, when we're looking at any of our medications, we see that, and sometimes just because of these disease states, and that's why I always tell y'all, check in with your patient, right? You see that we have an increased risk of that suicidal ideation that our patients can have. So when we start these medications, it's very good for you to make sure that you're checking in with them whenever they first start a medication. So typically within that month or two, when that medication is starting to pick up and actually work and hit their therapeutic levels, you should try to check in with them. The anticonvulsants that we have that are more likely to increase the risk of these suicidal ideations are all of the ones listed here. So your levetiracetam, which is one of our very, very popular medications. Do we see this a lot? No, but is it something that's possible? Yes. And because it can be lethal, that's why we have our black box warning. So make sure that you're looking at all of your medications that you have that are your highest incidence of that increased suicidal ideation. All of this other stuff I don't need you to remember. Of course, if somebody has a background of this, right, if they have a background of suicide attempts, suicidal ideations, you're going to want to try to avoid putting them on one of these medications first, right? Like I would try something else that may not be as effective, but I also know that they're predisposed to, like especially if they try to carry out a plan before, you're going to make sure that you're watching out for putting them on one of these medications, okay? And then all of this other stuff down at the bottom, like don't worry about it. Again, I want you to know black box warning for those suicidal ideations and which ones of my medications have the highest incidence of that suicidal ideation. Okay, let's take our 10 minutes and come back. We'll finish our Parkinson's. And I only have 50 minutes to do our 33 slides, so we're going to have to finish them. I'll answer questions at the end of that lecture.
That's what I said. Are you showing up this week? Say you are. Years ago, discovered America.
Yeah, I'm loving
I don't know what day it is. No, my wife probably has to work. Also, I don't mix my wife with my military stuff. Yeah, absolutely not. Absolutely not. No. Yeah, no, I don't mix my. I just.
You're like nice all around.
Yeah.
Oh, I thought my
Yeah, hear me out. Anything awesome, those are just
If my wife told me that, hey, you're gonna drive 2 hours and then you're gonna run, I'm not driving 2 hours.
Like, I broke my leg on the
I'll be like, I'm not driving 2 hours.
way.
We're doing, we're going, but for the thing I told you about all like the wine stuff, we're going on over that stuff too. That's like, Friday, Sunday. So I'm going up to Saturday. This is long game. If you have to get bored, so that's like a country.
Like, I'm not gonna drive.
So I'm going 1 hour. It's actually closer to go from Philly to Frankfurt. It's like that.
She didn't have to do quick stuff.
Yeah. Unless you guys. It's like
Oh my god. We're so
Stay away from big cities.
in Miami does? Thanks. Man, it's even worse in Miami.
My experience here has not been that bad. When we were in Maryland, I thought Texas drivers were horrible. When we were in Maryland,
Maryland drivers are another. But then again, I feel like everywhere I go, they're actually trying to outdo. It's crazy. Miami drivers are god awful.
they're like, not here.
Yeah, my wife comes from the road rage. Oh, I was like, yeah. Sure.
Yeah, are you in the wrong lane? Are you like in one lane? God bless. Well, y'all have to think how many training places are before. But if it's like 5 times, yeah, but thank God we found someone that's trying to like get out of it.
That's like not bad. I keep there, but like by the time they're like gone, I have to like get outside and like just like
That's not my favorite. To be like,
I'll definitely be the guy that's like this before I have to touch any patients.
I curse a lot. Especially in the morning, it's just not so hard.
Probably, yeah. Yeah. Plus, she's always usually times in a bit. So she's always like, always like, hard. She like touches me. She's like, why are you so cold? I'm like, listen, all right, just outside, you know, do it like just ambient air, just doing, you know, just natural that way.
Because it's working yesterday.
It's what?
All the ones I sent you.
Oh,
Huh?
all the ones because of the rings.
I sent you a
Creating family wants to be in.
popped up in my feed.
That's what I heard. Through the women were fine.
Fire, Casey.
After like right after like more walk like I'll clean walk and then after it's done, I can just clean it fast. I don't know why I hate my she's a military girl, so like her dad was there, so like she was all over the place. They ended up done settling in Jacksonville. But like she's all sorry, her mom is like pure German. Like she lived in Germany for 10 years of her life because they kept going back and forth between Germany and France. She's only been there maybe like It's only when we have time to go back. So it's only been there for most of my
Oh, I
time.
don't know.
But she's not bad. She didn't believe me. So when I took her, I'm like she's completely different. She's like a different world. We go to the gym, right?
Get my ass handed to me tomorrow.
Sports and my dudes on. It's gonna be all Telemundo. They're talking Spanish first. Like she was so.
Alright, our last lecture for this block. Y'all get to not see me for a whole. Okay, so, Parkinson's. This is one of those diseases that is very sad to see. And it is something where, again, we are not curing it. We're trying to use our medications to kind of slow down the progression of the disease for these patients. So when you're looking at your drug choice, you're trying to, we have two good options that we use, and we're trying to reserve some of our meds for later in their disease if they presented to you at a milder state. If they present to you and they're already pretty severe, then of course we're going to start using our big guns earlier on. But again, just understand we are treating their symptoms and trying to help improve like their quality of life and decrease the potential of mortality in these patients. ELOs, Parkinson's. So when we talk about Parkinson's, we kind of went over this. We were saying like, hey, there's this imbalance that we had with our acetylcholine and our dopamine, and we're typically seeing this kind of onset in the mid to late 50s, and then like I said, it continues to progress as that patient gets older. So just make sure that you're understanding again what our GABA does, right? And this is what we're thinking is the underlying cause of Parkinson's happening in our patient. So trying to, our GABA is inhibitory, so that's why you see like some of these issues that we have. A lot of the issues and the way that your patient is going to be presenting is like they're going to have rigidity issues. They're not going to be able to move. We talked about some of our drugs when we have that pseudo-Parkinsonism that can happen, or where we cause these issues in our patients. So understanding several different ways to get here. Usually with our drugs, we can remove them and we can see our patients start to get better. If it is this etiology where we have our dopamine acetylcholine imbalance, that is more so where our drugs are coming in trying to shorten that imbalance or decrease the imbalance that our patients are having. You do see here what I was talking to you about with that mortality rate. We do think that our medications are helping our patients live a little bit longer. So when we see that, we're always going to start treatment in our patients. So whenever they present, and this is the issue that they're having, we are going to put them on some type of treatment, okay? You see what they're typically dying from, but I just want you to know that this is our imbalance between our dopamine and our acetylcholine. These were our different medications that we looked at that have some of our drug-induced Parkinsonism. So we talked about our antipsychotic medications where you were seeing that, especially at higher doses. Some of our anticonvulsants, which are some of the meds that we just talked about, you can see some Parkinsonism there. We'll talk about these mood stabilizers a little bit in our antidepressants next block, and then we'll see some of our dopamine antagonists that we can use as well. That you can see some of that Parkinsonism occur. So when you're looking at this, just think about it's just the reason why we see these drugs on here. Some of them is because they work with serotonin, and so the inhibitory effects of the serotonin on that dopamine neurotransmission is kind of how you can see where we get this alteration, and then you have the Parkinsonism that ends up being a result on that patient. So just understand that we can also cause Parkinsonism in our patient, okay, with our medications. Okay, so my drugs. When I'm looking at my drugs, I'm doing it based off of how my patient is presenting. I'm also doing it kind of based on their age and how severe is their presentation. So we have our dopamine therapy that we have, and then if I'm having complications, I'm still having issues, motor issues, things like that, then I can adjust, of course, my dopamine therapy to try to make it to where it is more tolerable for our patients so that they don't have as many of those symptoms. I can also try to say, all right, what other medication can I add on to make my meds last a little bit longer? So we'll see where we're using duplicate therapy sometimes while we're looking at these. So the more dopamine that somebody has, the more likely they are to have those dyskinesias. So kind of put the D with the D, right? If I have a lot of dopamine, I can now see where I'm having complications from my treatment. You may have to back off and add on another medication to supplement for my disease state, right, for the Parkinson's, without giving me a super high dose of the dopamine, especially if I'm sensitive to it, okay? Because that's where you'll start to see them have that rigidity that we don't want. These are all of my different drugs that I have because remember, we had our acetylcholine and our dopamine, we had that imbalance. So now what I'm trying to do is I'm trying to get us back on an equal playing field, right? So if I can increase my dopamine level by using any of these methods that you see here, then I am decreasing the symptoms, hopefully, that my patient is experiencing, and I'm trying to slow down the disease progression. Does not mean that I am stopping it, I'm just slowing it down, okay? So I have anticholinergics, levodopa, my dopamine agonists that we're going to talk about, and my COMT inhibitors are my MAOB inhibitors that we have, okay? So when we look at these, you see the different mechanisms in which they work and how they result in an increase in your dopamine levels, okay? This is your treatment approach. So I was telling you at the very beginning, we have our levodopa sparing and we have our levodopa centered. Your levodopa centered is like your big gun, okay? You try to stay away from levodopa as long as you can because we do have some times where this medication can start to wear off and you have some other complications that comes along with it. So we try to save it to the very end if we can. We don't let our patients suffer, but we try to put it off. So most of the time you'll see us starting on that left-hand side with a dopamine agonist, your MAOB or your anticholinergic. You can see where if none of those are working, even if they're in the early stages of their disease, you're going to have to use your levodopa, okay? So that's why you see it down there at the bottom. If I'm not getting a response, even if my patient is younger, even if my patient presented and they're mild, if I'm not getting that response, I have to use my levodopa, okay? When you're looking at your levodopa centered, the big drug that we typically talk about is going to be your carbidopa with your levodopa, and then you can add with that COMT inhibitor or your MAOB inhibitor. Again, we're trying to say, hey, I want to reserve this for as long as possible. We'll talk about some of those dopamine agonists and your anticholinergics and why they're not as good for you at that point, okay? So we try to stay on our levodopa sparing side for as long as we can. And the reason we're doing that is because we kind of have what we call like a honeymoon period with our levodopa, and we get varying responses the longer that somebody uses it, okay? So that's why we're trying to save it. These are our medications that we can use. So you heard me say them on the previous slide, but now they're all kind of broken up so you can see where they fall. So your dopamine agonist that you have, we have our bromocriptine, pramipexole, ropinirole, and your apomorphine that we can use. Our analogs that we have are our dopamine agonists. Remember, that's another way to say an analog. We have our levodopa, which is typically paired with our carbidopa, which is an AAAD inhibitor. And then our muscarinic antagonists, we saw these before, right? So our anticholinergics. You have your NMDA inhibitor, your COMT inhibitor, and your MAOI inhibitors, okay? So a good summary slide for you to see all of the different drugs that you have, and we're going to talk about when we're likely to use some of these versus not using them. This is showing you where your medications are working. So now you have a picture that kind of shows you where my targets are. Big thing that we're looking at here is when we have our levodopa, your levodopa is a precursor for your dopamine. So levodopa gets broken down into dopamine. Dopamine does not cross the blood-brain barrier, but your levodopa can cross the blood-brain barrier. So if I can let my levodopa hang around for a longer period of time, I am now going to get some of that. When it does break down, it'll be already in the brain. And now I can have it, it's kind of like my Trojan horse, okay? So when you're looking at these meds, you do have some things where you're trying to just protect your levodopa from getting broken down so that you can get it to cross that blood-brain barrier. And this is also why sometimes when you see your levodopa, you'll see higher doses being needed because it does have to get across that blood-brain barrier, and some of it does peripherally get metabolized to dopamine, which isn't going to get to our CNS. So looking at our agonists that we have available, our mechanism of action is essentially us trying to say, hey, I am working on these dopamine receptors to try to get a response. My issue with these is that if I give too much, I can cause some of these issues that I'm worried about and what I'm trying to treat. I can cause more rigidity. I can cause more of those dyskinesias. So you have to be very observant when you're putting your patient on this medication to make sure that you hit the sweet spot with their dosing and that their symptoms are improving and not worsening. Okay, so this enzymatic conversion, we already kind of talked about that with it not being able to cross that blood-brain barrier, so therefore it's going to be able to work on the dopamine receptors as is because it is a dopamine agonist. We made it based off of our natural dopamine. Okay, so looking at our different receptors that we have, just remember we have a D1 family and a D2 family. When we talk about our D1 family, we're talking about our dyskinesias. When we talk about our D2 family, we're targeting things to help if somebody comes in and they're experiencing rigidity and that bradykinesia instead. So two different presentations that your patient will have. I will specifically just give you the word that they and how they are and how they're presenting, and we're just going to go through these drugs. You'll just pick the correct drug. We have different types of agonists. You have your selective and your non-selective, and you have your ergots and your non-ergot. When we talk about our ergots, you're likely to see more side effects with our ergot medications. We'll talk about these again when we talk about migraine, but these are older medications that you can see used, and then your non-ergots, those are going to have less side effects. They will have, of course, they're still going to have side effects, but they're not going to be as bad as when we're talking about our ergots. And again, I say that they're older, and the way that you can kind of think of this and how they started to see that these work, these are derived from fungus. Okay, so when we talk about them in migraines, when we talk about them in our Parkinson's disease, like they're old meds. We were using the earth for our medications, which we do not do anymore. Looking at our clinical use. So this is us trying to delay us from getting to that levodopa, right? We want to be levodopa sparing. So that's why we were on our left-hand side. Our milder situations, typically our patients are going to be less than that 65 years old. This is when we're pulling our dopamine agonist. You see that you don't have a lot of those complications where they have the off periods when we talk about levodopa. So what we'll see is like sometimes the medication will work and then it'll wear off and then they get stuck. And I kind of think about, did anybody watch Doom Patrol? They used to be like my favorite show. Y'all never seen Doom Patrol? Huh? Yeah. And so remember he was like, oh shoot, like, well he didn't say shoot, he said a lot of curse words. But when you think about that, like that's kind of how I think about and try to remember my Parkinson's. So you'll see like a lot of the benefits that we have is that we're sparing us, right? It's our levodopa sparing treatment, sparing us for using that levodopa. We're less likely to see those dyskinesias that occur, especially if we are going to use these at reasonable doses. Because remember, if I do have too much dopamine, I can still see those dyskinesias occur, which we don't want. But you don't see a lot of that happening if we have the right dose. They have a longer half-life, so therefore I also am not going to have to dose these as often. And then these free radicals, this will come up a little bit, but when we talk about a free radical, those are those helping our cells or are they damaging our cells? They're damaging our cells. They're not good for us. So that's a good thing for us to not have this be oxidized to a free radical because now I'm trying to preserve my cells for as long as I can, especially our dopamine cells, which are going to be the ones that are targeted in this disease. If somebody has psychosis or dementia, we could potentially worsen their symptoms that they're having, and that agitation that they're having. So just be very cautious in your older patients, because we have cognitive impairment that can happen, and we also have orthostatic hypotension that can happen. And if their blood pressure drops too low, especially when they're standing up, you have that fall, remember? So when our elderly patients, when we're looking at our dopamine agonists, just be very, very cautious, okay, when we're looking at them. And then real quick on this, when we talk about this psychosis or dementia, sometimes we'll also see where they have, they lack impulse control as well. So you can kind of see that in these drugs sometimes too. All right, our two products that we're going to talk about, these are our non-selective dopamine agonists. You have your bromocriptine and your ritodagine. When you look at your bromocriptine, this is an ergot. Remember I told you that these are older medications, so we don't typically like to use it, right? Made from our fungus. So our ergots are like last line type of things that we try to use when we are in this category of picking a dopamine agonist, or in the category of picking our levodopa sparing treatment options. But we have our ritodagine that we can use. It's a non-ergot. This one is also very convenient because it's a patch. They put on one patch every day, and it disperses that medication for them throughout the day. Okay, so if anybody has any issues or they don't want to take a medication every single day, again, great option for us. Adverse effects. When you're looking at these, and you can kind of group them together because some are specific to our ergots. So you see the pulmonary and the cardiac fibrosis, that is specific to your ergots. You're definitely likely to see that occur, as well as that vasospasm and the leg cramps, which are on the very last adverse effect. The reason why is kind of the mechanism of action of how our ergots work, but what you can see is that they will vasoconstrict, and sometimes you have where if you use a high enough dose of these medications, people can lose their digits, they can lose their limbs because we vasoconstrict it so much. So we clamp down, and that's not a good thing. We talked about some of that hypotension that we could see, the mental confusion, so this is why we were worried about it in our elderly patients. Contraindications. Relative contraindication when we're talking about that psychosis, okay? Because remember, we can aggravate it, especially in our elderly patients. Our MI and our active peptic ulcer disease, mostly when we're talking about our ergot again, so that bromocriptine. We see that we can have increased incidence of those peptic ulcers happening in those patients with their ergots. Okay? Looking at our more selective now dopamine agonists, you have your pramipexole and your ropinirole. These are both non-ergots, so that's a good thing for us. We will see that we use these quite a bit. When you're talking about your patient, remember again, this is on our levodopa sparing side, so more of our mild patient trying to save and reserve that levodopa. But what you do see is that you have your pramipexole that can still keep its punch, is how I remember it, in that advanced stage of Parkinson's, okay? So you can see where we will use this sometimes in combination with our levodopa. You can see that we add on this pramipexole as well. Both of these also help with RLS, or restless leg syndrome. So another clinical indication where we can use these medications, and then looking at your pramipexole, you see how it says possible neuroprotective effect. So when we're talking about that, just thinking of the fact that it can kind of help protect our dopamine neuron from being, from all of the toxic things like how we were talking about, like the oxidation and the free radicals and things. So this can also have, your pramipexole has a neuroprotective effect. It protects as well, okay? So when we use this with our levodopa, what you can see is that it'll help us not have as many fluctuations with the responses to our levodopa. So it kind of smooths it out and helps our levodopa work a little bit better. Your adverse effects that you see here, again, we have some hypotension, you have GI disturbances, those mental, the confusion, the hallucinations, those disorders where we're like kind of making them confused. Peripheral edema, again, more so with your pramipexole. So all of your things that kind of start with P are related to your pramipexole that we use for Parkinson's. When you look at this somnolence, again, that's a side effect of most of these medications that are in this class. Your apomorphine or apokyn. This medication is also selective. Typically, whenever we're using this, this is like intermittent treatment, not something that we're using for a very long time. And it's more so used in our patients who have their they're in their later stages of Parkinson's. So when you see these off episodes, essentially what that means is that their symptoms are coming back or they're worsening. Okay, so despite them being on medication, they're starting to have an off episode again. So you'll see us keep saying off episode, that's what that's referring to. You see that it is an injection that they're giving themselves. Whenever you are initially giving this medication, sometimes we will do a test dose in the office to make sure that they are not having a lot of these side effects like the nausea and vomiting that we'll talk about, and that hypotension is another big one that we initially worry about. So if you give them their first dose, if they took that first dose and it didn't work, we will not tell them to take another dose. That means that it's going to be ineffective, and what we're doing is increasing the likelihood of them experiencing one of these adverse effects. Okay? So if they take the medication, we're not going to be like, yeah, let's try one more time. We typically are going to stop them. You see that this nausea and vomiting is super high, okay? 98%. Super likely for it to happen, which is why we prophylactically treat them with our antiemetic, the trimethylbenzamide. We will give them that prior to them taking this medication. Sometimes we'll do this 3 days before. We'll start them on the antiemetic so that it's building up in their system, and hopefully it will combat them having to take this apomorphine. But if they don't know that they're going to have an off episode, right, they don't know that that's going to happen, the chances of us prophylactically treating them may be slim to none. Yes?
Are we just using that one because that's what we use?
So the reason why we're using this one is that it will work more on the CTZ area than any of our other antiemetics that we have. So this is the drug for this. Like if you see apomorphine, you should be seeing your trimethylbenzamide. Like they just go together. It hits higher concentrations there and it's more effective. So looking at our orthostatic hypotension, hallucination, dyskinesia, these are the same things that we were seeing before with our other meds. So just make sure that our big thing that we see here, you know how typically I tell you I'm not asking you about nausea and vomiting. This would be something where I'll be asking you about nausea and vomiting because almost all of your patients may experience it and you're going to prophylactically treat them for it. You see your contraindications listed here because I can, of course, worsen my hypotension if I am worried about potentially causing a thrombus, and then that sulfite sensitivity. The reason why this is on here is because of the way that they made the medication. If somebody has a sensitivity to that sulfite, they can also have a reaction to the medication. Okay, so just understand, great medication for you to use, but it is used very sparingly. Okay, this is later on in the disease because they're starting to worsen. All right, looking at my analogs that I have now for my dopamine. So I have my carbidopa levodopa. Am I still in my levodopa sparing? No, because I have levodopa as a part of this pill. This is a combo pill that we can have for our patients. We are looking at the carbidopa component of it. That's what's inhibiting that AAAD. And typically when we talk about our AAAD, what that is doing is that is what breaks down our levodopa into dopamine. And so if I inhibit that, I can now have my levodopa around for a longer period of time to cross that blood-brain barrier, because remember my dopamine does not. Whenever you're looking at this peripheral conversion, you can also, there's just an added benefit of decreasing again the breakdown of your levodopa so that you have more levodopa around, okay? When we look at our mechanism of action of our levodopa, essentially we're trying to say, hey, let me cross the blood-brain barrier to replenish that amount of dopamine that is depleted in the brain. And so then I can get broken down once I've crossed the blood-brain barrier. I can get across as levodopa. My dopamine cannot get across. Okay? So my carbidopa is essentially kind of how we talked about like a beta lactamase inhibitor. That's kind of how your carbidopa is. It is trying to prevent the inhibition or the degradation of your levodopa to dopamine. It's blocking that. That is what that's its job. Okay? So that your levodopa can then go into the brain and say, all right, I'm here to replenish the dopamine. It will get metabolized to dopamine, and then you start to see the decrease in those levels. That's how this is working. Also, looking at your clinical effects, you see that you can get less effect on a tremor, not as good of an effect on our tremor, but I can improve the overall disability that person is having, right? So their rigidity should be decreased, and again, that mortality, which is what we're definitely after. Looking at your carbidopa to levodopa and the way that we make our pill, so the brand name of it is called Cinemet, and we have several different formulations of the Cinemet. So when you see it, your left side, so the 10 would be your carbidopa portion, and your levodopa portion would be the 100 that you see, or the 250, the one that's to the right, okay? So that's just telling you how to like see what level you're giving them. So the 1 to 4, the 1 to 10 is kind of how we're seeing that. So again, I told you my levodopa levels are higher because I'm trying to get a higher concentration of that dopamine in the brain, and I need a higher amount. When you see that your patient is starting to experience like actual symptoms, they're starting to have the disability where they're not able to move, that's whenever you're going to treat your patient. When we talk about our honeymoon period, this is essentially why we try to spare or save our levodopa. After the first 3 to 5 years, you'll start to see where your patient isn't going to respond as well to that levodopa. It's going to waver a lot more. You're not going to get the peak response that you typically see when you initially start them on the medication. So that's where we have their off periods, right? Because I'm out of my honeymoon period. That 3 to 5 years is just like when you get married. We're good at the beginning. After that 3 to 5 years, we got a couple of off periods where we're gonna have to repair it. We gotta readjust, right? So same thing with our medication. When they have those off periods, we may have to go back and look at our dose and say, okay, let me readjust this, let me fix this so that we get out of that phase again, okay? So you will start to see those honeymoon periods more frequently the longer that somebody is on their medication. When they do have this happen, they will do what is called, they will freeze. They have freezing. And when they freeze, it is temporary, but it is involuntary. They can't control when that happens. So again, dose adjusting to try to make them now respond again, and why we save this levodopa is because as the disease progresses, they will have more of those freezing periods, okay? So your control release, anytime you think about control release, think of it as like, hey, I can let them not have to take this medication for a very, very long period of time, but I can also have this slowly released throughout their body over the entire day, and hopefully it will prevent them from having the freezing occur. When you see your immediate release, this is for like, they can't, so I guess the way you can think of it is some people will start to see that their medications are not working. And they'll have a slow like progression of where they're like, uh-oh, I'm about to have one of my little episodes, right? But there are times where they may not. And so that's where we would want something that's gonna act a lot quicker to help our patient. But if you have somebody who is more, they're more controlled, and they kind of have those prodromal symptoms, I guess you could say, that occur, then you can treat them better with our slower release. Okay? Anytime you see slow release, control release, sustained release, long acting, we don't want to crush it. The coding and the way that we made it is why it is a slow or a long acting medication. When you crush it, you crush the coding, you crush that matrix, and then it is an immediate release drug, okay, which is what we were trying to prevent. Our contraindications, again, looking at the issues that we would potentially have We already talked about these are psychotic medications that we have. When you're looking at your non-selective MAOIs, we talked about MAOIs too when we were looking at our first block. So just remember that, like, if I have a non-selective MAOI, what can happen is that it can increase the amount of norepi that they have, and then that can lead to a hypertensive crisis. So those were our meds that we talked about, like your isocarboxy, your phenolzine, those types of medications, okay? So if it is a MAOI, I will tell you that it is a MAOI, so that you know in this situation. Looking at your precautions that you have, again, that peptic ulcer disease, if somebody has any type of cancer, you're definitely worried about that because of that levodopa portion. It is a precursor to some of the melanin that we have in our skin. Our adverse effects. So when we're looking at these are essentially the ones where I was telling you, like, hey, we might have corrected too well. We have too much dopamine now. So whenever I have too much dopamine, outside of me having those dyskinesias, that's our extreme situation. And the ones where it's not that bad, I don't see too many big deals with my adverse effects, except for my orthostatic hypotension, my postural, which is similar, hypotension, okay? So we're gonna tell these patients, hey, make sure you're getting up very slowly. Give yourself a minute to kind of reorient yourself to the room before you just get up and start walking around. And then you'll also see those, the same things that we saw before, our hallucinations, and then cardiac arrhythmias is something that's a little bit different here, unless you were looking at your ergots. Now, my dyskinesias, remember dopamine, too much dopamine, dyskinesia, D and our D, right? So this is, again, because our dose is too much for that patient. So then we can try to pull back whenever we're talking about that. Remember, our dystonia was like those involuntary muscle contractions that our patient could have. So what we would do, we are going to back off of our levodopa dose. I could add on another medication, but do we want to add on another medication for a symptom that we cause? If we can avoid it, we want to back off of our dose. If you see that when I back off of my dose, now I'm starting to have a lot of wearing off, I'm having a lot of freezing, then you can add on your anticholinergic or your amantadine, okay? These are the long-term effects of our medication. So if I leave them on them for a very, very long period of time, I have two different things that can happen. I can have my wearing off, where you're telling me, like, okay, I can take my medication, I take my medication every 12 hours, right? But what I'm starting to see is that, like, 8 hours, I'm starting to have my symptoms return, right? So my medication is wearing off quicker than I am expecting for it to happen. So these are my then options that I have, right? How can I fix that? So if I am wearing off, my medication is not lasting for as long as it is supposed to, then I can say, cool, let me give you a dopamine agonist. Let me give you one of those MAO-B inhibitors. Let me give you a COMT inhibitor, so that I can now say, hopefully your medication will last a little bit longer with the help of these agents added on. Or I can say, you can take this more frequently now. So instead of you taking it twice a day, now you're taking it 3 times a day, right? Because now that drug can build up in their system a little bit better. So if I told you, hey, I was wearing off maybe 2 or 3 hours before, now make that my new dosing schedule. Try 3 times a day before you put me to 4 times a day. Your on-off phenomenon, this is essentially where your symptoms are just coming back randomly. There's no rhyme or reason. You can't find the pattern. They're just off periods, okay? So your wearing off is my medication. I took it how I was supposed to, and I can tell you that at 8 hours, 8 to 9 hours every day, my medication stops working. I start to feel my symptoms come back. Whereas my on-off phenomenon is like I'm all over the place, and randomly I'm having my off periods or my freezing happening. Okay, so same approach that you have, but now what you're thinking about is that you're trying to say, hey, maybe I can limit or make sure that they're not fluctuating with how much protein they're having in your diet, because we think that that can interfere with our levodopa absorption. Okay, so then we go to the diet versus trying to change the frequency, but same meds, that you have to treat both of these conditions. All right, our MAO-B inhibitors that we keep seeing. So when we look at these products, they're fairly good products that we have. You see they end in Geline, right? So Selegene, Resalagene. This is again for the symptom control that we have. This is also something that we can use to try to spare how much and how high our dose of our levodopa can be. You see that for the most part is an adjunct because I'm having issues with my movement, my motor skills, okay? Avoiding our medications that can also increase the risk of serotonin syndrome. We already touched on serotonin syndrome. So make sure that you remember anytime you compound these two things, you are likely to see that happen, okay? So watching out for serotonin syndrome is a big deal with our MAO-B inhibitors. All right, so looking at your Selegene that you have, this is going to irreversibly stop our dopamine metabolism, which therefore means that I can now increase the amount of dopamine that I have. This is not the same thing as what you're looking at your MAO-A, which is what we talked about when we were looking at acetylcholine, right? So don't think about these as the same options that you had before. We're talking about two separate things. MAO-B, remember MAO-B, okay? And then looking at this insomnia side effect, you will see where some people say like the later that they take it, they find it very difficult for them to go to sleep, so they have insomnia. So that's why you see that you try to do it early afternoon. So like try to have their last dose a little bit after 12 if you can. If you can get it earlier, then that's better for your patient. We already talked about this in conjunction with our levodopa, trying to decrease that dose that we may need of that levodopa and also help with some of those motor issues that they're having. If you are looking at patients who have mild disease, you can try this to see if it works. It may or may not work, so that's why we saw it on our left-hand side. So just make sure that you're understanding for the most part, when we're using this, we do see it later on, but you can see it in that mild situation. Adverse effects, same things that we have been seeing before, and then you see why we were talking about our insomnia because of amphetamine that we typically use for what? What are we using amphetamines for? ADHD, right? So when we're talking about that to try to help somebody focus, that's the last thing I want to do when I go to sleep. I want to focus on sleeping, not all of the things that I have to do, okay? So that's why we try to get it as early as we can for that last dose for them. Your Resalagene or your Azilect, this one, again, MAO-B, when you're talking about your benefit of this, you see that your Resalagene can help with that neuroprotective effect again. So very, very potent also. It's more potent than our Selegene, so up to 5 times more potent. So great medication. You will see that if somebody isn't tolerating the Selegene very well, we will go to this. I have been seeing your Resalagene used a little bit more lately because it is more effective. We aren't really worried about that insomnia anymore because you see I don't have the same metabolism pathway here. When you're looking at this hypertensive crisis potential, what you'll try to do is you'll try to say, hey, you can potentially test them in clinic and give them a dose in clinic to make sure that they don't have this occur. Because you will see some of your big things that you're worried about is that hypertensive crisis occurring, which is where the blood pressure goes up really high and we're trying to correct that. And then watching out with our tyramine-containing foods. Does this sound familiar? Remember we talked about this, right? They had those fermented foods and then it caused our drug levels and everything to become more toxic. When we look at this also, big thing with this is that it is, this drug is irreversible. And so when we talk about like the doses of this medication, it's very variable. So start low, go slow with this medication, okay? No tyramine. Our COMT inhibitors. So when we're looking at our COMT inhibitor, essentially what this is doing is it's increasing our dopamine levels and trying to let our levodopa be able to get into that blood-brain barrier, so cross it, right, and then stay in there for a long time. So I think about it as like, again, this is my one of my protectors that I have. Looking at my clinical use, trying to help me have less wearing off episodes. So it's trying to decrease that fluctuation that I see. We are typically going to add this to our carbidopa levodopa. It is not something that we use by itself, okay? We are always trying to say like, hey, can I add it on to this? I have very rarely seen this used alone, okay? Looking at our adverse effects, increased dopamine. Remember we said our dopamine dyskinesias, but we can now add some diarrhea, another D, okay? All of these other things are the things that we had already been seeing before, our hallucinations and all those things. Your entacapone is another COMT, is a COMT inhibitor that you have. And then you can see that with your entacapone that it can discolor the urine. So again, make sure that we're letting our patients know that before we just put them on a medication, because that's something that they can see. And then your hepatotoxicity, even though it's rare, it is something that can be fatal, okay? We also, because we typically are seeing this used with our levodopa carbidopa, what's not on here is you can also see orthostatic hypotension with this as well, okay? So that is something that you can potentially see also. But these are your bigger things. All right, so your tolcapone, entacapone, and your Stalevo, this like reminds you of the mafia a little bit, right? Tolcapone, okay? It's like, what do we need to take out, okay? So when you look at your tolcapone, make sure that you're seeing that this has a black box warning, okay? That hepatotoxicity that we were worried about, although it's rare, if I see a black box, that means that it could be fatal, so that's why I'm worried about it. So baseline and then continue to check on them to make sure that they're okay. You don't have to have this. It is advised by the manufacturer, not necessarily a forced program like we've seen before. But again, you can kind of lump it in that category. They want to make sure that the patient understands that they have that increased risk for the hepatotoxicity, and they don't want to be held liable for it. So they like to see that informed consent if somebody has failed the entacapone before you put them on your tolcapone, okay? All right, so this is like reserved because of our black box warning that we have. Your entacapone that you have, again, making sure that you're understanding that not crossing our blood-brain barrier. Which one crossed the blood-brain barrier? Levodopa, okay? So again, just extending that life, helping us. And then this is a newer one that we have, our Stalevo. This is the one where we now took our entacapone and our carbidopa, levodopa, and instead of having them take 2 tablets, they can just take that one and get all 3 of those drugs. So therefore, I have increased adherence from my patient, okay? Because they don't have to keep taking several pills throughout the day. So real quick about this, the black box warning and why we're doing that informed consent, so that you kind of put in perspective. So there was a study that they did, and like I want to say over 23 years, there were only 7 people who had experienced the hepatotoxicity. But it is still something, again, where when you have those patients experience that and you don't catch it, they can die. So out of those 7 people, 3 of those people died. So that's where the informed consent came from as to why they want that. Okay, our anticholinergics, we've seen these before. So you have your benztropine and you have your trihexyphenidyl. When we talk about these, they're blocking the amount of acetylcholine, so therefore you don't have as many of those symptoms that they're experiencing, okay? We're trying to restore that gap. We want to close the gap with our imbalance of our dopamine and our acetylcholine. Clinical use that you have, now I have something that is good for me to use for my tremors and my rigidity, okay? Kind of trying to help us restore that balance. So big thing for us to look at. You see that for our drug-induced Parkinsonism that we have, especially when we're talking about our antipsychotics, we can use these anticholinergics to try to help reverse that, in addition to trying to decrease the dose of those agents or switching them to another agent that doesn't cause the Parkinsonism that they are experiencing. Your EPS, when we talk about our EPS or our extrapyramidal symptoms or disorders, we have several different medications that can cause them. So when we're looking at this block and for your test, make sure that you're understanding the difference between which type of symptom they're occurring, like they're experiencing, right? Rigidity versus the dyskinesia versus me using a term EPS, like we talked about when we were doing our anti-psych on the very first day. So then you can say, if I gave you this and I was like, hey, does this help with TD? No, this does not help with TD. We have specific drugs that are for TD. We have specific drugs that are for tremors and rigidity. So make sure you know what drug goes where. And then when we talked about our antipsychotics, that was a very good foundation for you to see what each of these tremors and what each of these, I guess, involuntary movements look like. Adverse effects, our anticholinergics, remember we're drying things up. Looking at our amantadine or our NMDA inhibitor, that is your mechanism of action when we're talking about how it works. Initially, this started out, remember we talked about this was for our flu. All of this is essentially the same things that we had talked about when we looked at amantadine a little bit because we saw this. But clinical use, again, you can use this for your dyskinesias. And then looking at our adverse effects, this reticularis rash, you see the picture there where he has that rash that's kind of on the back of his legs, that he can experience your CNS effects. Make sure that you're renally adjusting, especially in your older patients, because that's where we're mostly worried about that, and then taking it with food. These are going to be our complications that our patients can experience, right? So when we see these, if you had a question that was saying, hey, your patient is coming in, they're complaining of this. This would be the problem. What I want you to know is, all right, what do I do about it? Okay? So I'm not too worried about you understanding this. I want you to know, if I had this issue, what can I do to help fix that? Okay? Sometimes whenever you see this, smaller, more frequent dosing, right? So that means that now I'm having my patient take something more often. Are they able to take it more often? Are they going to remember to take it more often? Are there any barriers to why they may not be able to do that? Take all of those things into consideration whenever we're talking about these different options that we have when it comes to changing doses and how frequent we're taking the medication. So on this, the big idea, what is the complication that they're having, and then what are my different options that I have that are available. And then looking at our question that we have, 73-year-old male has Parkinson's, COPD, and hypertension. He's having gait disturbances coming back before it's time for his next dose. His meds that he has his carbidopa, levodopa, selegiline, and he has tiotropium, probably because he has his COPD, and he has lisinopril for his hypertension. Which course of action would you recommend? Okay, if I told you that he was having symptoms, then our A would be a good option for us to use, right? So this is a short lecture, but make sure you're going through and looking at what do I do when my patient presents this way. Because remember, I'm going to put them on that levodopa carbidopa as their disease progresses, but I'm going to have my response doing this often. The longer that they're on it, the more unpredictable their response to your levodopa carbidopa is going to be. Okay? So what we would do here is we would increase his frequency because he's having the wearing off. So that goes back to this chart right here where we said we can do any of these things, or I can just potentially increase how often he's taking it instead of adding on another drug. So if I were approaching this as a physician, right, I would say, hey, I would rather him not have two medications that he's taking and take one. And if he didn't respond to that, then I would add on another med. Okay? Okay. I am going to decide what I'm going to do about a review. I will be writing your exam so that I can do a review if I do one. If I don't do it in person, what I would do is post it for you guys. So I'll give it to you. I'll let your class leader know if it's one that you can just go online and you just answer some questions. If I do it that course, I will be around if you guys need anything. I will be in my office. On Monday and Tuesday, my availability is going to be limited until after 4 o'clock because I will teach over there from 1 to 3, but I'm also leading a DHA course on those 2 days. So if you need me, you can text. I can reply to you through text, but I won't be able to have like people in the office because it's a Teams thing that I'm doing, okay? So Monday and Tuesday, if you need me, you're gonna have to wait until after 4, and then I will still be here for us to talk if you need to, okay? I'll let you know about the review so that you can put it out. If we do one in class, if we do one in person, it will probably be on one of your days during lunch, okay? Thank you, have a good day.